of the impact of PA catheters in critically ill patients. And at the end of the day, there's really no data to suggest that PA catheters actually, the information that you get from them improve outcome. So is the catheter dead? Well, I don't know if it's dead, but it's not doing well. And it probably will be replaced and is being replaced by less invasive, more effective means of understanding cardiac output. Just a very brief overview of when you do have vasospasm and you do induce blood pressure, how do you do it and why do we use one versus the other? Again, the details we'll go through another time, but these are the vasopressors: phenylephrine or neosynephrine, levophed or norepinephrine, dopamine, and pitressin or vasopressin. In general, we use these two, right? We use levo and neo. And in general, we use levophed. The reason why we use levophed is that it acts on both alpha and beta. So it will give you some pump help in terms of inotropic of the heart. It will increase your heart rate a little bit, and it will certainly increase your afterload and try to encourage more blood flow to the head. There are obviously downsides of levophed. Phenylephrine is a pure alpha agent, right? It's a pure alpha agent, so you just get pure afterload with no benefit on the heart at all. That's why we actually prefer levophed over neosynephrine. There are exceptions to this rule. If you've got somebody who's very tachycardic, then you're going to want to avoid levophed and avoid dopamine, and you're going to want to go with neosynephrine. Neosynephrine is actually a fairly good drug to lower heart rate and increase blood pressure. Dopamine, we don't use very much anymore. There's nothing the matter with dopamine, and at high doses of dopamine, it's almost the same drug as levophed anyway. Once you get to 25 mics of dopamine, it's essentially the same drug. Pitressin is a secondary agent or pressor to be used typically in sepsis. That's its clear indication, and it's fixed dose vasopressin at 0.03 units per minute. The other drugs that we used to use more, and sometimes we use, is dobutamine and milrinone, not so much phenoldiprem. Dobutamine and milrinone are different drugs, but at the end of the day, they actually increase the pump capacity of the heart. They're typically used in patients with heart failure. Sometimes our patients are in heart failure from a neurocardiogenic cardiac failure, that cardiac stunning. And when they are, dobutamine or milrinone, but dobutamine is usually the drug that's been used most and studied most for severe cardiac decompensation at a lower dose. One of the side effects of dobutamine is vasodilation, and it particularly affects the head. That might be very good for vasospasm, but it also raises ICP. So, although it's not a profound effect, it is there, and I've certainly seen patients on milrinone and dobutamine with elevated ICP, so you just have to sort of be wary of it. In the last couple of minutes, we'll talk a little bit about some miscellaneous things, one of which is a very common scenario, because we're talking about inducing blood pressure. Typically, if you have one aneurysm, you're at higher risk for having another, right? So if you have an MCA that came in that ruptured, you've got about a 20% chance of having another aneurysm somewhere else in your head. And those are visualized on the initial angiography. So it's not that uncommon when the angiogram report comes up and says left MCA ruptured, because that's where the blood is, and then it says incidental A1, P1, contralateral PCOM, so they've got 3 other aneurysms. But because there's no blood in that region, and anatomically on the angiogram it doesn't appear that they have blood, there's no small blood clot there. So you have a patient with a ruptured aneurysm and a patient with 3 unruptured aneurysms. Well, once the ruptured aneurysm's been fixed, you're still left with 3 unruptured aneurysms in the head. So the question is, are those at risk for rupturing during that hospital stay? And is there anything that you're going to do to promote that, which obviously you don't want to do, because it's a very common occurrence. Well, this was a study back done in 2002, and they looked at 40 patients with 124 aneurysms, 73 of those aneurysms were unruptured and unsecured. In other words, the incidental aneurysm that you find that didn't rupture. If you look at those patients and those patients underwent hyperdynamic therapy in terms of, significant blood pressure greater than 200 or 180 to 200 or 140 to 180, none of them rebled, or none of them bled to begin with, I should say. So there's really no evidence based this study, and there have been lots and lots and lots of other anecdotal data that we have to suggest that acute hypertension, induced acute hypertension, will rupture a natively unruptured aneurysm. So, and this comes up a lot like, well, aren't you worried about that other MCA that hasn't bled? Well, am I worried about it? Well, sure I'm worried about it. You worry about everything. But I can tell you that in the 2,000 patients plus that we have treated over the last 10 years, we've had no patients rupture from induced hypertension. Finish up with a little bit about colloids versus crystalloids, like albumin versus sodium. At the end of the day, I can tell you that there's really no meaningful difference, at least not that we can tell. They're both right or they're both wrong. This was a big Cochrane, which is a big database review. This was in 2004, and at the end of the day, there was no difference from randomized trials of using colloids versus using crystalloids. This was a study that was published a few years ago. This was an Australian study called the SAFE study. It was a comparison of albumin and saline for fluid resuscitation in the ICU. Again, these are sort of all ICUs, not just neurologic ICUs. And there was really no difference in albumin versus saline for resuscitation. When they say no difference in mortality. And they looked at heart rate, MAP, CDP, and urinary output, and they were all pretty identical with regard to how the body seems to respond. There is some data to suggest that in the setting of severe sepsis, that albumin seems to work a little bit better, but nobody really knows the answer to that question. And there's some hint of data that in the setting of traumatic brain injury that albumin works a little better, but again, nothing to take to the bank. I'm going to end with hypertonic saline now, a little bit, in terms of volume expansion in ICP. This is a study that was done a few years ago in China, and what they looked at the effect of 23% hypertonic saline on cerebral blood flow and ICP and mean arterial pressure in patients with grade 4 to 5 aneurysmal subarachnoid hemorrhages. So these were severe subarachnoid hemorrhages in documented angiographic severe vasospasm. What they did is they gave them 23% bolus of hypertonic saline over 20 minutes, and they looked at transcranial Doppler, they looked at intracranial pressure, they looked at xenon CT, which is a perfusion study. It's very similar to CT perfusion, and they looked at sodium and osmolarity. And what they found is that after they gave this 23.5% bolus of hypertonic saline, the CPP increased by 26%, the MAP increased by 10%, the ICP fell by 47%, and there was a significant confirmed increase in cerebral blood flow. Okay, so what they chose to look at is that what effect was 23% on cerebral blood flow in subarachnoid hemorrhage patients, and it was pretty profound. Now, it doesn't last forever, and you need to do something else as you're doing the 23%, but that is why this study, and then a lot of other data to support it, is why it's our reflex to, if we think someone has a neurologic change, or we think someone's in active vasospasm, as we're doing something to treat the vasospasm, like nicardipine, like angioplasty, like whatever, we're going to give 23% if they can tolerate it. Dr. Buckman wanted to know what the time frame of hypertonic saline was. And again, I'm going to give a whole talk just on sodium, which should put everybody to sleep. But this is sort of a little teaser of it. These are the parameters. This is the first treatment dose of hypertonic saline, and this is the second treatment dose of hypertonic saline. This is arterial blood pressure.